It's my pleasure to introduce our two moderators for this next session. Dr. Amanda Mixon is an assistant professor in the section of hospital medicine at Vanderbilt and a research scientist at the VA Tennessee Valley Healthcare System. And Dr. Mixon co-leads our pilot and exploratory studies core. Dr. Sandra Simmons is our other moderator. She is a professor of medicine in the Division of Geriatrics at Vanderbilt and also has roles in the Tennessee Valley Healthcare System's VA administration. And along with Dr. Mixon, she co-leads the USD Prescribing Network's pilot and exploratory studies core. So I'm going to turn it over to Dr. Mixon and Dr. Simmons. Thank you.
Great. Good afternoon, everybody. Now that we're all fueled again, we're going to talk about some of the research that the network has funded over the past few years. And our first speaker is Dr. Ariel Green. She's an associate professor of medicine in the Division of Geriatric Medicine and Gerontology at the Johns Hopkins University School of Medicine. She's a member of the USD Prescribing Network's first junior investigator intensive cohort.
So I'm really honored and excited to tell you about our research project that was sponsored by the network. This focuses on patient-preferred language to achieve goal-aligned deprescribing. It's also very weird to not be presenting on Zoom. This is my first time doing this in 2 years, so I feel a little weird. So we've heard a lot today about the importance of communication with patients and families about deprescribing. And so we chose to focus this project on the language of deprescribing. We know from previous research on shared decision-making that patients who are engaged in decisions tend to choose more conservative treatments and receive less unwanted care, including medications. We also know from previous research that patient-centered care and communication is linked to higher patient satisfaction and quality of life. Furthermore, as we've also heard today, patients and caregivers may not recognize the potential harms of medication. So, for example, there was a qualitative study by Kearns and colleagues with dementia caregivers in which many of them expressed that they perceived antipsychotics as very safe, in spite of the fact that there's a black box warning on the label and that there are well-known serious adverse effects. And finally, we know from research by Emily Reeve that patients have high levels of willingness to deprescribe. So across cultures and across countries, her work has shown that if a doctor recommends it, patients have high levels of willingness to deprescribe. So we did a nationally representative survey that had two parts. The first focused on the specific rationales for deprescribing. So what patients wanted to hear, what rationales for deprescribing a doctor could use that would resonate the most with a patient. And the second part focused on, it's difficult to speak in a mask. The second part focused on patients' overall or more global health outcome priorities related to medication use and how that was associated with their willingness to deprescribe. So as I mentioned, we use an online nationally representative survey panel, the Ipsos Knowledge Panel. We had 835 respondents over age 65, which was a 70% response rate. And we presented them with two hypothetical examples. The first was a patient taking a statin an older adult taking a statin for primary prevention. And the second was a patient taking zolpidem for insomnia. In the first part of the survey, the specific rationales, we tested 7 different phrases a doctor may use to recommend deprescribing the medicine. And the statin and the zolpidem examples were tested separately with different phrases. For the sake of time today, I'm just going to focus on zolpidem. We used the best-worst scaling method in which respondents were presented with 3 phrases at a time, which is thought to reduce the cognitive burden because they're not presented with all the phrases at once. And we were able to refine the survey and the phrases with various groups of stakeholders, including the network's stakeholder panel. And so these are our key results for the zolpidem module. So these are ranked from most preferred phrases to explain deprescribing on top to least preferred on the bottom. The x-axis is the number of times each phrase could be chosen by all respondents, and so because the phrases were presented multiple times, each phrase could be chosen a total of about 2,500 times. And so the first thing to point out is there was a lot of variability in preferred phrases. Even phrases that were chosen as most preferred or most likely to make a person stop zolpidem was also chosen by many respondents as least preferred. And then you can see that the most preferred phrases, 2 of them dealt with side effects. So the most preferred phrase was one that said, I'm concerned that at your age there's an increased risk of side effects from this medicine. Another preferred phrase, the third most preferred was the one that said, I'm worried this medicine will cause more harm than good. The second most preferred phrase for deprescribing zolpidem was one that emphasized shared decision-making and said, I'm concerned this medication is not good for you in the long run. Let's work together to slowly reduce the dose and get you off it over time. The least preferred phrase was one that dealt with function and said, this medication is not likely to help you function better in the long run. And the second least preferred phrase was one that emphasized non-pharmacologic treatment and said, we can treat this problem of insomnia without medication, but it will take some time and effort. So in the second part of the survey, we focused, as I mentioned, on overall health outcome priorities related to medications. And so we had 2 separate models. The outcome in the first model was willingness to stop the preventive medicine, which was the statin. And the second model, the outcome was willingness to stop a symptom relief medicine. And the example they were given was zolpidem. The predictors in these models were agreement with 2 universal health outcome priorities statements related to medications. The first statement was, I'm willing to accept the risk of future side effects, such as falls or memory problems, to feel better now, and that was tested in the zolpidem model. And the second statement was, I would prefer to take fewer medicines, even if it meant that I may not live as long or may have bothersome symptoms sometimes, and that was tested in both the zolpidem and statin models. And these models were adjusted for things like relevant health status, race and ethnicity, health literacy, how they felt about the overall number of medicines they were taking, and ability to afford their medicines. And just briefly, so first of all, we found that there was high willingness to stop each medication class, with slightly higher willingness, slightly more people willing to stop preventive medicines. So 61% were willing to stop a preventive medicine if the doctor recommended it. 50% were willing to stop a symptom relief medicine if the doctor recommended it. 59% prioritized avoiding future side effects over feeling better now, and 36% prioritized taking fewer medicines over not living as long or having bothersome symptoms sometimes. And then in terms of our main results, so we did find that respondents who prioritized avoiding future side effects over feeling better now had higher odds of being willing to stop symptom relief medicines, and you can see the adjusted odds ratio there. And respondents who prioritized taking fewer medicines over living longer or avoiding bothersome symptoms had higher odds of being willing to stop both the preventive and the symptom relief medication class. And so in conclusion, we found that the major driver of willingness to deprescribe was side effects. We found that for zolpidem, respondents also preferred the phrase that emphasized shared decision-making. We found that I guess it's not surprising, but we were surprised that the statements about functional status, that statement was the least preferred. And I think it suggests that some patients prioritize symptom relief over functioning in the long term or over non-pharmacologic approaches. And then finally, the variability that we found and the association with health outcome priorities related to medicines suggests that it's very important to elicit patients' health outcome priorities related to medication use before initiating a conversation about deprescribing. And I just wanted to thank the network, first of all, for funding this, and then all of the collaborators and mentors on this project.
So we have about 2 minutes to take some questions, if you'd like to come up to the microphones.
All right. Andrew Zullo, Brown University. Great talk. I think those are some really interesting results. One thing I'm curious about, for the functional results, do you think that maybe one potential reason those results were observed is that older adults actually conceptually didn't know what function meant as a phrase or a term? Or I think you understand my meaning, so I'll leave it there and let you fill in.
Yeah, no, that's a great question. And I do think some of that was related to the fact that I think that the people responding to the survey, as is often the case with patients that we see, didn't perceive that they had any functional problems. So the way we phrased it was, I don't think this will help you function better. So I think as geriatricians, we think that people take a sleeping medicine to help them sleep so that they can function better, but I don't think they perceived that they had a problem with functioning.
Hey, Ariel. Mike Steinman, UCSF. Wonderful work, and I've cited it a lot, your paper on this topic. One of the ways I've sort of interpreted the results potentially is that some of the more preferred phrasing might reflect more of like the physician or the clinician expressing concern, like, I'm worried about you, I'm worried you might have side effects. And some of the least preferred ones have the potential at least to be more paternalistic, like, you shouldn't take this medicine because we can treat you without medicines, or you shouldn't take this drug because it's going to make you function worse. And I'm curious, like, if you were able to disentangle that a lot, in part from the way you phrase your questions, and if you think that sort of difference in paternalism versus more sort of physician expressing concern might explain part of the findings.
So that's a fantastic question. So we did not try to disentangle that in this particular survey. That would be a great next step. We did, I would say, in some qualitative research that we've done, we did find that, and I'm actually going to be presenting this tomorrow, we did find that expressing or really taking time to understand the patient and family perspective first, so that it's, so really understanding their experience. For example, if a caregiver is giving a patient with dementia benzos to help them, with behavioral symptoms, we did find that it was really important to, frame it as like we're not, not in a paternalistic way, but like first understanding where they're coming from.
Our next speaker is Dr. Daniela Moga. She is an assistant dean for research in the College of Pharmacy, an associate professor in the Department of Pharmacy Practice and Science and the Department of Epidemiology, and an affiliated faculty member in the Institute for Pharmaceutical Outcomes and Policy at the University of Kentucky.
Good afternoon, everyone. Really great to be here with such an awesome group and following the presentations from outstanding researchers. I will be presenting on a work that's kind of in progress, so I will not be able to share results from this study or finalized results. I will present a little bit on the rationale and the design of this study that is assessing a medication optimization intervention in rural Appalachian Kentucky. It's a very long, I can never come up with very short titles, but I have a great collaborator who's a physician and is into finding the most catchy acronyms to make my life easier when I present. So this is the AMOR Kentucky study, and AMOR comes from Assessment of Medication Optimization in Rural Kentucky. Before I proceed, I would like to thank the US De-Prescribing Research Network, Mike and Cynthia, for including me and giving me the opportunity to get funding for this study, which has been funded through an ADRD administrative supplement to the US De-Prescribing Research Network. So thanks again. So I will start with this is not supposed to be the most comprehensive list, but kind of like the thought process and some important aspects of why we thought a study like this was necessary. and why was it, how it would encompass the different aspects that might be unique to this population. So it's pretty well established that medications, polypharmacy, inappropriate medication use are big problems for older adults in general, and even more so for those that suffer from dementia, ADRD, and other cognitive impairments, related cognitive impairments. In fact, the World Health Organization has included addressing polypharmacy as one of the priorities in the patient safety challenge initiatives. And they even highlight the need to put emphasis on the uniqueness of the population that's comprised of people living with dementia. Medication complexities in people with dementias are also well studied and bring more complications. And one could think that a new dementia diagnosis could be seen as an opportunity to maybe take a close look at the medications a patient is taking. But that's not always the case. And our group actually looked using longitudinal data from the National Alzheimer's Coordinating Center Consortium, which is a consortium of Alzheimer's disease centers in the US. And we looked to see what happens when a participant in that longitudinal cohort is being diagnosed with dementia. See whether there is any change in polypharmacy and number of medications they are using. And to our surprise, instead of seeing maybe a decrease, we saw a year later an increase in a number of potentially inappropriate medications that had been used compared to counterparts without dementia. So this is a big problem. To make things even more complex, in patients with dementia, one cannot only focus on the patient, you have to take into consideration their caregiver. So involving and engaging both the patient and the caregiver becomes an important focus of any deprescribing interventions. And I will mention one thing in terms of barriers, because they were described in the literature, and kind of preliminary look into our data seemed like things might be changing, or maybe it's this unique population. It's the fact that one of the important barriers that were perceived in the prescribing interventions in patients living with dementia was resistance from both the patient and or the caregiver. And then the other thing I wanted to mention is the fact that we are lacking strong evidence to support how to best intervene and how to best implement interventions that are really targeting patients living with dementia. Now, on top of all this, if you think of the underserved population, now you have an even more complex issue. And so we try to look at all of these aspects. And so after a long introduction, I finally got to the focus of our study, which is patients living with dementia and related cognitive impairments in underserved area, which is, in our case, the rural parts of Kentucky, in Appalachian Kentucky. So this is a pilot study, and we have two specific aims. The first one is, again, taking into consideration the resources and the uniqueness of the population, we are trying to see whether using telemedicine as our approach to delivering the intervention could really help with reaching out to this underserved population. So this being a pilot and us trying to gather information on the possibility of upscaling an intervention like this, we wanted to assess whether it's feasible and acceptable for all those involved to participate in a study like this. And we also want to gather information that will help design future studies that will be a larger scale studies. So we want to gather some preliminary information on outcomes. And you've heard Dr. Campbell talk a little earlier today on the outcomes and what's needed. So we are looking at outcomes on medication appropriateness and number of potentially inappropriate medications that are being used by these patients. And in terms of more clinically relevant outcomes, and this being a population that is suffering from dementia or other cognitive impairments, we are looking at cognitive outcomes. Last but not least, we also want to see how the intervention, an intervention like this, will impact the caregiver, and look at the caregiver burden from the perspective of managing medications. So again, we are trying to tackle the complexities of medication prescribing cascades, and I actually have to give a shout out to Dr. Vorey, Scott Vorey. I saw, and I kind of borrowed his cartoon from a presentation he gave a few years ago at the pharmacoepi meeting that really captures the complexities and how hard it is to tease out the prescribing cascade and its role in polypharmacy and inappropriate medication use. So we are looking at medications holistically, and we are trying to approach these as in a multidisciplinary intervention that will put risks and benefits in balance for each individual patient and their caregiver, with really taking and centering all of the interventions and recommendations around the patient and caregiver's preference and needs and their values. So a brief snapshot of the study design. This study is taking advantage of an existing telemedicine clinic that's serving this population. So these patients are already seen by neurologists that's servicing the clinic. And we are using data from those visits to abstract and identify patients that might be eligible for our intervention. So in the table on the bottom right corner, you see some of the data we are collecting and what's the source of data. So all the cognitive assessments are coming from that telemedicine visit. In addition, and that we are collecting data that's study specific, and so those are things related to acceptance and preferences towards deprescribing, and also burden for the caregiver and an appraisal of self-care for the caregiver as well. So we are looking at patients that are 60 years and older that take at least one medication that is deemed potentially inappropriate. Where are we today? We are currently recruiting, and I think we were a little more optimistic at the beginning than we are where we are today. So far we screened 61 participants. We got 15 refusals, and we are still learning of the reasons behind the refusals. Some of the participants did not want to have a study-related pharmacist look at their medications. They wanted to continue with their own. So that's a good lesson for us in thinking for the future. Total enrolled today, I think as of today, it's probably 12, not 11, but we have on average 76 years old. About half of them identify as females, with an average of 14 years of education. Something that, it's not what you want, but it's the reality of conducting this study in rural Appalachian Kentucky. The population is mostly non-diverse when it comes to racial background. Then on average, they were taking about 16 medications. And what you see in terms of stopping and whether they would be willing to stop a medication if their physician said that they could do so, that was very encouraging. You have the two tests that the two surveys they were done, one for the patient, that's the one for the RPATD for cognitive impaired individuals, and then the one for the caregiver. Of the patients, 70% said, yes, I would consider. If my doctor said it's okay, I would consider. And 15% said, maybe. The rest was no, but the percent was really small. And the caregiver, nobody disagreed or strongly disagreed that they would not consider, they would consider. So it seems like they want deprescribing if it's deemed appropriate by their physician. And so to kind of wrap up the preliminary data on this study, we are now in the follow-up. We have 9 that we already intervened upon. And I forgot to mention one important detail. This is a pre-post design, so we don't have randomization involved because, again, it's more of a preliminary gathering data on our participants. So that's where we are today, and hopefully before the end of the funding period, we will be able to recruit all the participants we said we will. And with this, I would like to also acknowledge my collaborators along with our study participants, and to thank you all for being here today. Thank you. I went over time. Apologize for
We can
that.
take about 1 or 2 questions.
Thank you for your presentation. I'm Barbara Zarowitz at the University of Maryland. A couple of things that I understand to be unusual characteristics of that population. I don't know how prevalent they still are, but there was a period of time when the pretty strong use of over-the-counter supplements, most of them self-made. So when you count the medications as 16, are you making any provision for all of the other herbal weeds, roots, you know, the other teas and things that this population consumes?
Yes, that's a great point, and I'm glad you asked this question. Yes, we did, because I strongly believe that it's not only about prescription medications, but everything else they are taking. They might not even perceive as potentially harmful, and we know that there are potential interactions between supplements and prescription meds.
Sure.
Yes, so we are definitely looking at those as well.
That's great. I also noted that the educational level that you documented, 14 plus or minus, is pretty high from, again, what we know about this population. So I'm wondering if by virtue of the fact that they're already being followed in a telehealth clinic by a neurologist, if in a way you're not self-selecting out a more advanced educated individual, perhaps with lower issues related to social determinants of health.
Yes, that is also a great point, and one. So this telemedicine clinic and the physicians that's providing the care in the clinic is actually also part of the Alzheimer's disease. So it's kind of they know, and there is definitely a skew towards a more educated population, even those that come from more rural. But we do have some that are less educated. Again, this being a very small number, at least at this point, it's hard to look at anything that would be stratified further. But I think we would still be able to gather some preliminary data to help us think in the future on how to reach out to really those that are totally underserved and might not even be aware of such opportunities.
Our next presenter is Dr. Sarah Vordenberg, who is a clinical associate professor at the University of Michigan College of Pharmacy, and she's a board-certified ambulatory care pharmacist. She's a member of the USD Prescribing Network's second junior investigator intensive cohort, as well as one of our pilot awardees.
Well, thank you for this opportunity to speak with you today. So I'm a pharmacist by training, and I'm very interested in how do we effectively communicate with older adults when having conversations around deprescribing, particularly because the medical appointments where these often happen are very time limited. And so today I'll be talking about a survey that I've conducted along with colleagues that you'll see in just a moment, and we've titled it Harm and Type of Medication Matter, when older people make deprescribing decisions, a survey across 4 countries. Here you will see a list of my collaborators, including, I'll give a shout out to Nancy Schoenborn, who has been fantastic in working with our whole entire team. I would also like to highlight that this particular team is composed of pharmacists, geriatrician, as well as health psychologists. So we've had a very diverse team come together. And we span 4 different countries. And so I think that's really led to the work that I'll be sharing today. And of course, I appreciate the funding from the US Deprescribing Research Network. The objective of this study was to conduct a pilot to explore the extent to which the type of medication and the rationale for potential discontinuation of that medication influence older adults' willingness to deprescribe. And so I will just briefly summarize the methods we used. So we conducted a cross-sectional survey-based online experiment. We worked with Qualtrics to recruit individuals who were 65 years and older from Australia, the Netherlands, the United Kingdom, and the United States. And when participants opened the survey, they saw information about a hypothetical patient who we called Mrs. EF. And Mrs. EF takes 11 medications, and you can see on the right-hand side of the screen the medications and how we presented it to the participants. We wanted it to feel like as real life as possible, to show this is her medication regimen. And we provided information about her medical history, social history, family history, even her caregiving responsibilities with her spouse. On this next slide, I realize it's perhaps a bit small to read, but what I'm showing you here is the participant flow and study design. In total, in this first survey, there were 5,311 participants who were randomized into 2 groups. We used a 2x3 experimental design. 1/2 of the participants received a scenario in which the primary care provider brought up the idea of discontinuing simvastatin, whereas the other 1/2 of participants received a scenario where the language was all the same, except we were talking about discontinuing lansoprazole. So simvastatin we described as being a preventive medication, prevent a heart attack or stroke, whereas lansoprazole was to treat indigestion. I alluded to 2x3 experimental design. So you can also see below how we divided participants. We randomized them to either receive a rationale about the medication lacking benefit, potentially causing harm if it was continued, or a combination of lack of benefit and potential for harm. Just to talk for a moment about our results. Here on this screen, I'm showing you the mean participant level of agreement with stopping a medication by country and rationale. The primary outcome question was the extent to which individuals agreed with deprescribing when it was brought up by the primary care provider. We used a 1 to 6 Likert scale, with 1 was strongly disagree and 6 was strongly agree with deprescribing. And so you can see that in general, participants were open to the idea of deprescribing. There was more positivity towards stopping the lansoprazole, so actually our medication that was more symptomatic focused, rather than the simvastatin. And then the other part that I'll highlight is across the different rationales, and then also when you look at within the countries, there was similarities in the results. Here, I'm not going to talk through the entire ordered logistic regression and all of our statistically significant findings, but I'll just highlight a few. Individuals in the Netherlands had a higher level of agreement with stopping a medication. I will note that it was translated, and so they completed that survey in Dutch. In addition, I thought it was quite interesting that if a participant in real life reported that they had taken a medication that was in the same therapeutic class as the scenario that they received, so either a statin if they received that scenario or a PPI if they received the other scenario, if they reported taking that medication in the past, but not currently, they had higher levels of agreement with stopping the medications. Moving on with the same ordered logistic regression, medication-related characteristics that were significant included, once again, lansoprazole. There was higher agreement with stopping that medication. And also, when participants only received the information about the medication potentially causing harm, we saw higher agreement. For time's sake, I'll just highlight here that we looked at some personality traits and some psychological factors that were predictive of agreement with stopping the medication. For example, if for affective risk perceptions, that would a person be anxious or worried that their health would worsen in the future if they stopped the medication or without the medication? So that makes sense that it's in the negative direction. And you can also see that there were several attitudes towards both deprescribing and polypharmacy that were predictive. So as I move towards our conclusions, I'll just highlight a few limitations. Of course, this is exploratory in nature. We did do a second follow-up study that I'm currently analyzing the data for. It's the same structure, except we looked at 6 rationales for why a person might be asked to stop simvastatin in that case. Furthermore, obviously these are individuals who completed an online survey, so we shouldn't assume that they will make the same decisions in real life that they would on the survey. However, we're hopeful that this work will give us some insights into what's important to older adults when they have these conversations around deprescribing, and then we'll be able to build some future research off of this. So with that, I'll take any questions.
Thank you. We have a few minutes for questions. I'll ask the first one. So, what do you think, since you had asked the question about, did the person take a medication in the same class that you were asking about? Do you think that that matters? I mean, it sounds like it did in your regression analysis, but in clinical practice, do you think that that also sort of is relevant?
That's a great question. So certainly there's literature to say people's personal experiences with deprescribing influence their subsequent willingness to deprescribe. I guess the most direct way I'll answer the question is if you want to check out poster 42 after this session. So after the individuals answered, responded to our primary outcome statement around agreement with deprescribing the medication, we gave them a fill in the blank section. We asked them to tell us why. And so we've conducted a content analysis to look at a little over 2,000 responses for people who strongly agreed with deprescribing, and then we're doing some subsequent work around people who strongly disagreed with deprescribing, but that's been a little bit more complex. So I think those responses that are free text will give us some more insights into the things that really matter to them, like their personal experience with medications.
That's great.
Hi, this is Scott from UF. That just spurred a thought that I just had too. What about if it's like a friend or something who had experience with that medication? Because I'm trying to think of, what was said earlier about marketing. I think that's a good way to say that, this person that's known stopped taking this medication, is doing fine. Is that a way to target that as, kind of more on a global effort? I mean, we look at the COVID vaccine and all the celebrities that said, I got my COVID vaccine, what kind of influence did that have? Could that something else be studied and kind of been proven, so then we can start doing market research to say, hey, President Obama stopped smoking, therefore you should stop smoking type of thing, or another medication. So I think that, there's something to with celebrities. And I know that that's been studied in terms of celebrity. Was it the person from the Today Show that got the colonoscopy and showed an increase in colonoscopy? So I think that there's something to that. So I'm wondering if that could be expanded upon in future research.
That's really interesting. We didn't include that in a study. We did have a question asking if they lived with anyone who also had experience with these types of medications. They didn't present that results today, but I think your point about other people who have influence on one's lives is important too. Thank you.
Our next speaker is Dr. Robert Wahler. Dr. Wahler is a clinical associate professor in the Department of Pharmacy, practice at the University of Buffalo. He and Dr. Singh co-lead Team Alice, an initiative at the University of Buffalo, doing impressive work advancing research, education, and practice change around deprescribing. And Dr. Wahler, along with Dr. Singh, are also US Deprescribing Network grant planning awardees.
Okay, well, thank you everyone for welcoming us here. And I want to start out with, what the heck is this Team Alice thing? It is available on our website. It's actually, we did a presentation on one of the USDeN webinars as well. But I just want to give a brief outline. An older woman in our community was injured, went to urgent care, received a prescription for Flexeril. She felt better later that day. She never took it. Her neurologist said to her on her next appointment, never take this medication, bad for you, okay? Subsequently, she ended up back in that same health system in the hospital, and within a week, she was delirious and then septic and then died in the hospice that I practice in. They restarted the Flexeril on readmission to the system. So we are based upon what would have saved Alice. So I give you that quick background just so you understand, the team that we have. Dr. Ranjit Singh and myself are the co-leads of this group, and similar to the previous presenter, we have a multidisciplinary team. I can't claim international, but we have a multidisciplinary team that work on our projects with us. And one other thing I did want to say, and Cynthia and Mike didn't pay me to say this, but because this is a planning grant, Amanda and Sandra has helped us out. We've been in contact with Justin Turner. We've been in contact with Liz Bayless. I'm probably forgetting some of the other contacts that we made. But through this whole process, we've received assistance from the network. So if you're looking at a planning grant, you certainly, this is that network. It's funny, we're finally actually seeing people in real person for the first time, because we received this just before the pandemic hit. So let me go on then. So our initial plan, as we said, it was a planning grant for a NIA R21, R33, and I put some of the aims down here. Increase patient caregiver awareness. So our focus was on patient-driven deprescribing. Using the story, so we developed a series of videos that were funded elsewhere, and the link is at the bottom. We have a YouTube link for that. To identify if they have an abrupt symptom, is that because of a medication, the Jerry Gerwitz quote that many of us have in our presentations. The second part of that was to test the impact on patient caregiver educational intervention on the interaction between physicians and patients. Our deprescribing actions taken across the system, what has happened, and avoidable changes in avoidable hospitalizations. And hopefully many of you are sitting there going, wow, they really bit off a lot there. And that's kind of what we learned as we went through this process. Here's some of the progress to date, and again, this is because we're building to submitting a larger grant. So this is some of our preliminary work. We revised the study design on consultations, as I had mentioned, and review of the optimized protocol. We pivoted from an in-person design, pandemic, to a stepwise mail-order phone intervention with activation and reinforcement. And we expanded on intermediate outcomes because we also worked with the data harmonization group, and one of the comments was don't miss, we're looking for changes in hospitalizations, but don't miss the things that you might be able to capture in the middle. So we refocused on that. We commenced the pilot work that's just coming to an end actually right now from the RRF Foundation for Aging. That was the grant that helped us to develop the videos. And literally the last, I just got an email today that there were 30 stuck in, these are older individuals. Not everything was being able to be answered online, so we use that thing called US Mail. So some of them were stuffed away somewhere in the university, and we're just getting some of them now. But we should have enough data to go with our first abstract to American College of Clinical Pharmacy, which is in November, that is coming up. At the same time, because we wanted to talk about some of that other data, we've been working with the Regional Health Information Organization in our area called HealthyLink, and we just, a little about a month ago, received a full, well, I shouldn't say full, a large data set that will help us to actually tease out that. So we've been very much paying attention to the data harmonization, the outcomes group, and we'll be able to apply that as well. And along that same time, in similar presentations, talking about stakeholders. Who are our stakeholders? And we have engaged with 2 large primary care practices and are further working with our Elder Voices group, who helped shape what the videos ended up being. I can allude to that more, but we have a couple posters that you can look to as well. Unfortunately, these are the second, so Sorry, I changed this slide, and I guess it didn't get in there. What I wanted to show you here was this is the preliminary work that we have done. So we have a number of papers that have been published in the areas we needed to build that pilot data. We have some posters that were presented. Some are being presented at AGS, and they're here today as well. And we have a number that are still in progress. So we had to shift a little bit. We ended up not going for that original grant. We had ongoing challenges. We needed more preliminary data. We needed a more robust clinical outcome measurement. So those are the things that we're still developing. And some other things came along. Other sources of funding that build upon our strengths and our progress. And what funding opportunities are out there. So what we've ended up doing, and this one has just been awarded, Jennifer's over there. Jennifer Stoll's the PI on this one. Deprescribing by addressing health system complexities for older adults with multiple chronic conditions. So again, a shift in maybe patient population. So we're using that RIO data to explore different relationships between the risk factors and the outcomes. We're using more of a participatory approach with patients and their caregivers to gain some insight into multiple chronic condition patient experience. And then part of the AIM-2s then is focusing on the transitional cascades. And I saw a couple good posters on cascades. So we'll be talking with you guys. The other one, well, the other two, I should say, Dr. Singh's PI on this one, AHRQ R18, entitled Patient-Driven Medication Safety Learning Laboratory. So again, using this a patient and care partner focused, we're looking more here at care transitions and how education of these individuals can help them protect themselves. So we're actually working with the different practices that we've partnered with to get patient-driven work insight. So that we can reduce geriatric harm, improve care. And there's, so the aims we split up across a number of phases. The problem analysis phase, and I highlight the one here where we put together a, I think, innovative way to monitor patients. If you think about Alice's story, she went into the hospital, she came out of the hospital, she went to rehab, she went back and forth a number of times. And nowhere along that, well, it wasn't until her daughter actually said, why is she so delirious? And they looked at the medications and they found the Flexfro. Okay? It wasn't until that phase, nobody else in healthcare thought through, why is her mentation changing like this? Okay, so part of our protocol is monitoring patients at the hospital to identify symptoms that might indicate medication harm. And I make a note here, just before coming to this conference, we found that we have our letter of intent for another grant, which is highlighted here, rapid proactive monitoring of medication problems during prolonged hospitals, PALT says. We're going to be submitting that one. It's not funded. We're going to be submitting it. But we think it interesting. I was talking with some of our pharmacist colleagues, and what we're doing is building a network of primary care, inpatient, and post-acute long-term care pharmacists to identify potential medication harms that could have, did it put them in the hospital? Did it prolong their stay? What type of harm did we see? The other two parts of this are design and development. So basically, we're going to learn about this process. We're going to design some interventions to address what we learn, and then we're going to implement and evaluate them. And then the last one, Dr. Singh's PI on this one as well, is the NIA Impact Collaborative. And this is where we are, he's participating in the Scholars Program for patient-driven, deprescribing, and primary care patients living with dementia or their care partners. And again, this is where I talked about in consultation, we shifted to say, if anybody's been watching the NIA grants that are coming out, many of them discuss patients living with dementia. And we thought, are we missing an opportunity? And should we shift where we want to go? So again, my presentation a little bit different. I don't have data or outcomes. We actually, this was a planning grant. So this is what we were able to achieve using that. Questions?
Thank you. We have time for about one question.
Or not.
Well, I'll ask one, so,
Okay.
because we've been talking about this for a while. So, what was so we knew you had some challenges working with the Regional Health Information Organization. Can you talk a little bit to the audience about what those challenges were in case they're interested in doing similar work?
Yeah, certainly. So one thing was IRB. We're getting this large data set from participants across our region. And we had to make it very specific that it was going to be de-identified. We could not, get, so that was one issue, and it was more of a university-wide. I think the other part is the outcomes from that, and that's why we've been working with data harmonization, is if we want to be able, can we tease out, when a medication's been deprescribed, because we're not getting access to electronic health records of the different practices, we are just getting the RIA. So those are some of the major things that we found as a challenge.
Our next presenter is Dr. Jinjiao Wang. Dr. Wang is an assistant professor and postdoctoral program director at the University of Rochester School of Nursing, and also a core faculty member at the Hubbard Center for Nursing Research on Aging. And Dr. Wang is a member of the USD Prescribing Network's 3rd Junior Investigator Intensive Cohort.
Hello, old and new friends. In a way, I feel like this is the Deprescribing Got Talent that where I'm going to give you my performance in a minute. I'd like to first thank USDeN for funding my work and giving me the guidance and resources for doing so. So I am Jinjiao. I'm from University of Rochester. I'm a nurse by training and also a researcher. Today, what I'm going to share with you is what I've learned in our USDeN funded study. We call it the Home Med. Everything takes a village, and this is my village. We have people from medicine, inpatient care, primary care, post-acute care. We have pharmacists, we have nursing, and also our funding sources that we are grateful for. I feel like I can basically skip the background because the stage is already set. By now, you already know deprescribing is a wonderful thing to do. It's challenging to do. It fixes a lot of problems that in the population that we care for, so I will skip that. What I'm going to share with you is a intervention design study or intervention development study that we've been able to do with USDeN HHQI support. Is to design a deprescribing intervention that is more pragmatic, that works with existing workforce, and this workforce is home health care. I know some of you are not based in the United States. Some of you are from the other side of the planet. So just give you a little bit background about the context. In the U.S., there is a type of care called home health care, and it basically serves 2 types of population. One is post-acute care. So after patients are discharged from the hospital or post-acute SNF, patients go home, and then, but in that recovery process, they also need some support from people to visit their home. That's when our nurses, our PTs, OTs, speech therapists, social workers, and home health care aides visit the patients in their home and help them. Another population that home health care serves in the United States, and it may be different in other countries, is that patients who are chronically homebound. And that is covered by something called Medicaid. Medicaid is the insurance that the US government provides for people who are socially disadvantaged, the low-income population, and Medicare is what we talk about for the post-acute home health health care services. And home health care has no copay. So if the patient is discharged from the hospital or post-acute care, and if the providers feel like there is a need for patients to benefit from home health care, there's no cost for the patient to receive home health care. So that is the reason why I chose home health care to be my incubator for the deprescribing work. The goal of the study is to develop a deprescribing intervention using input from HSC stands for home health care, primary care, inpatient care, clinical pharmacy, and patients. What I'm going to share with you today is what we learned from the round 1 qualitative interviews that we have been able to do with 3 panels. Let me see if so it's a qualitative semi-structured interviews that we did over the Zoom or over the telephone. Because of pandemic, that's actually what we end up doing. We were fortunate enough to interview 30 stakeholders. That includes 9 patients, 11 home health care nurses or clinical directors, and 10 providers from primary care, inpatient care, post-acute care, and clinical pharmacy. What I want to point out is 2 things. One, the patients are from the Rochester region. And some of you may not know that Rochester is ranked as #1 in childhood poverty and #2 in overall poverty among all the US cities of similar sizes. So we have a large population that are underserved and don't have enough resources to purchase or pay for private care. The home health care nurses and clinical directors come from 8 different states in the United States, and as you can tell from the slide, they're quite diverse in terms of their geography. So our intention is that we know home health care in different regions. They may operate under different resources. They serve different populations. We wanted to be able to capture a device perspective from home health care. So what did the stakeholders tell us? The first thing is I call it the quarterback. Sorry. And I'm not going to read through all the quotes because in the interest of time. I'll share with you one of the quotes that, for example, the second one, the PCP said, PCP stands for primary care physician, I think that as a primary care provider, I'm kind of the quarterback for the patient. And as you can tell from the other quotes, it's resonated by the PCP, the patient, the hospitalist, the pharmacist, and because of the space limit, I wasn't able to include all the quotes also from home health care as well. The second theme is home health care facilitation. My buzzword for it is treasure hunt. So this is the quote from one of the home health care nurses that we interviewed. They say, when we get in, we do brown bagging. We let them put all the medications from their cupboards, from the kitchen, from the restroom, the second floor restroom, the second bedroom, somewhere under the sofa, on the coffee table. It takes about 20 minutes or sometimes half an hour to gather all those sources. And then we let the patient lay all out on the kitchen table. And we first ask the patient, okay, tell me, what do you do with these medications? And if the patient said, well, I kind of don't know, you already had a clue that the patient's probably not hearing or there's some problems. If the patient is able to pronounce it and tell you what they're doing, then you have a better sense of, okay, maybe this patient have a better grasp of what's the patient that they should take. What I wanted to point out here is in the treasure hunt, we not only hunt prescriptions, we also document and assess OTCs, sleep meds, herbal medicine, medication that are shared among family members. And what we have learned so far during pandemic is that patients, because of transportation issues and inability to gather their medication, have started to share medications with their pets. Oh. This is the quote from one of the pharmacists who said, home health care nurses can be our eyes in the patient's home, which I find to be quite powerful. And from PCP as well, you can see quite consistent. The third theme is communication, and I call it the gaps or the black box. Because the patient has, in home health care in general, have 9 diagnoses. They take 15 different medications. They have multiple providers. And sometimes, because of various reasons, one provider might not want to deprescribe another provider's prescription. So it gets really complicated when we care for a population that has all of that, plus cognitive impairment, add in ADL limitations, and care transitions. So we are dealing with a hot mess here. And is reflected in the quotes. One of the PCPs, which I found interesting, is that she said, I know that these patients are hard to take care of because of the potential gaps in care coordination. So she said, I try to write out extensive visit notes in my plan, my thought processes. And if anyone has issues with the medication in the past, I put it there. I leave it there purposefully for the other providers to view. I find that to be a very good practice for care coordination as well. One of the patients said that she feels like even though the communication may be a little bit affected because of the care transitions, she does benefit from having a home health care aide visit the patient. She said that my home health care aide, she's with me so much. Her and the doctors do quite a bit of talking on the phone. They communicate with her when they need me to do something. They work out the best way to get me to do it. And when she works through them, let them know how it's worked out. She's very informative. She works very closely with me and my doctor. So in a way, the home health care, in this case is the aide. Most cases is a nurse who takes care of the medication for the patients. Could be very informative for not only the patient and also the providers. One thing I found interesting is because home health care providers visit the patients in the home, and the visits are not as continuous as we would like. Normally, there's about 2 visits from nurses, maybe 1 or 2 from PT per week. So as you can see, there is quite a couple of days sometimes, a gap between the previous visit and the next visit. And what the home health care nurses told us is that they try to do everything in the home. If you find a discrepancy in the patient's medication list, or if you find something missing in the medication list, or if you're so concerned that if you leave this patient's house and don't do anything, the patient's gonna fall or be admitted to the hospital, call the PCP when you're in the patient's home to get a conversation going, and give the patient a plan for what to do if you do experience the side effects. So that I find to be very, very helpful quote that they share. The next one is patient-centered approach. One of the PCPs shared with us that ultimately, it's about what is the best for the patient. I think that just kind of summarizes it so nice in a nutshell. Patient also shared similar quotes of things like you have to make sure that the patient really bought into changing the medication. And they also talk about the need for a support person, the comfort they get from having effective communication with their provider. Sometimes it's not just that problem solving with the provider, is that the patient feels like there's some hand-holding there's care for them, there's availability of the provider to address their question that gets them to feel comfortable with deprescribing. The trust in provider is very, very important. The patient, this is just one quote I share, that the patient said that my doctors are attuned with me in some kind of way. I just love my doctors. I have so much confidence in them. And this is not just one patient, it's all of our patients. We have patients who have been with their PCP for 50 years. And what they've told us is that whatever I do with my health care, I always run by my PCP. The home health care nurse shared a few quotes about education, where they said that education first comes best one-on-one when you sit down with the patient and share with them what you think is the good thing to do. Importantly, it is very helpful to not just ask the patient what you're taking, but show me how. Ask the patient to show me how you take it. Show me how you what is your system to make sure that you take all the medications at the right interval. If you see the patients have it quite organized, for example, if the patient had a morning routine of drinking coffee and they have a tendency to forget things, what they can do is to put the medication next to the coffee machine as a reminder. If you see a patient and when you ask them the question, what is your system? And they look at you in such a blank gaze, you know that they don't have a system, so home health care nurse will come in to help the patient to build a system to help them with take medications. That includes using the pill box, or if the patient has a dispenser, teach them how to use it. For some patients, they don't like to use pill box, and that's okay. We help them to build individualized plan. Okay, so that is the theory. That is what looks good. But what got in the way? There are some barriers in home health care, for example, the payment structure. And some of you who are from the single-payer healthcare system, for example, in the UK, in Australia, and Canada, I know that in some countries there is something called home medication review that's covered by the government. That thing is not available in the United States. So the payment structure in home health care actually does not encourage nurses to do too much with home medications. The documentation burden, that the information about medication is buried somewhere in the 485 form for PCPs to sign the order for home health care. There's no marker for the providers to see where the medication information is located. The fact that medication review is often done only on the first visit, and there's a lack of routine follow-up to see what changes have been made in medication. These are some major ones. And last one, I want to focus on the rebranding. When we asked the participants to share with us their insights about deprescribing, what they said is that the word deprescribing sounds a little negative to them. They like things like optimization or safety. They like that kind of words instead of deprescribing. The patient feel like deprescribing make them feel like their providers are not spending enough time or paying enough attention because of the word D. So there may be something there that we can do. Barriers in terms of primary care, the biggest thing is time. Nobody has enough time, and I'm sure you know, to do everything. It's hard, and because of the limited availability, it's hard to get a timely response from PCP. And also for patients who don't have a lot of support, it's hard for them to access care at times for deprescribing. Gaps in care, as I'm sure you know, data silos, everybody's seeing a different list. They're all barriers that were mentioned in our interviews. And I think I'm going to sum this up with a positive message, that we know that primary care and patient-centeredness are very important for deprescribing success. We know that there are hurdles on the way. We also know, however, that home health care is a readily available system there that can facilitate deprescribing for providers. And of course, there are things to do, but at least we now know what needs to happen before that deprescribing can happen. So knowing what is lacking is the first step to do that thing that is lacking. And with that, I'm going to end my presentation, and thank you for your attention.
Thank you. How about one question, since we're a little bit over time?
I committed to the microphone, so thank you. First of all, good job in presenting that information in a usable way. I appreciate that. We all know that there are a number of personas of medication users and patients out there, like Savvy Sally, who looks up her information, versus someone else who just does what they're told. Do you feel like that's represented? Those personas are represented in what you've obtained so far, or what's your plan to get to saturation from those different patient perspectives?
Yes, so I definitely see the personas represented in the data. For example, we have patients who are very savvy with technology and use e-record to communicate with their PCP all the time and get all their questions answered. We have patients who self-advocated for deprescribing because she was a biochemist and she knows what's going on. We also have patients who don't have internet, no computer, who was waiting for our participant payment to pay for her Medicap because she lives in the place, government housing, and she was being evicted as we were interviewing her. So we've seen all that. What I wanted to call a little bit attention or caution to is try not to stereotype, because the patient who might strike, as you, as a well-resourced person, may turn out to have a lot of barriers there that we're not aware of. So yes, there are different personas, but I think it is later in the care, or at least after some conversations, before we can figure out what kind of barriers are there and what facilitators can help this patient.
Thank you.
Thank you.